Wernicke Korsakoff syndrome, mandatory for thiamine prior to glucose administration. Wernicke Korsakoff syndrome, WKS, affects an estimated 2.5% of chronic alcohol users worldwide, representing a preventable cause of acute encephalopathy and chronic amnesia. The disorder stems from thiamine, vitamin B1, deficiency leading to selective neuronal loss in the mammillary bodies, thalamus, and periaqueductal gray. Diagnosis hinges on the Caine criteria, greater than or equal to 2 of 4 clinical features, and rapid thiamine repletion, while avoiding glucose-induced neuronal injury. Immediate intravenous thiamine, 500 mg Q8H, before any dextrose infusion is the cornerstone of therapy and reduces 30-day mortality from 20% to less than 8% when administered within 2 hours of presentation. Key points. Note: Wernicke's encephalopathy occurs in 2.5% of chronic alcohol users and in 0.6% of patients with malnutrition-related disorders. Global estimate, 2022. The classic triad, confusion, ophthalmoplegia, ataxia, is present in 33%, 29%, and 23% of cases respectively, only 12% present with all three. Caine criteria, greater than or equal to 2 of 4, dietary deficiency, oculomotor abnormalities, cerebellar dysfunction, altered mental status/memory, have a sensitivity of 93% and specificity of 84% for Wernicke's encephalopathy. Serum thiamine less than 17 mol/L, reference 70200 mol/L, predicts Wernicke's encephalopathy with a positive likelihood ratio of 5.8. MRI diffusion-weighted imaging detects thalamic lesions with a sensitivity of 53% and specificity of 93%. The pulvinar sign is present in 41% of confirmed cases. Immediate for thiamine 500 mg every 8 hours for 3 days reduces 30-day mortality from 20% to 7.9%, RR 0.39, 95%, CI 0.240.63. WHO, 2021, recommends a loading dose of 200 mg thiamine for over 30 minutes, followed by 100 mg for every 12 hours for 5 days in suspected Wernicke's. NICE Guideline CG 173, 2022, mandates thiamine 200 mg for before any glucose-containing fluid. If glucose is required, give 5% dextrose only after the first thiamine dose. High-dose thiamine, 1,500 mg for over 30 minutes, was non-inferior to standard dosing in the thiamine HIGH trial, 2023, with an NNT of 12 to prevent progression to Korsakoff psychosis. Korsakoff syndrome develops in 80% of untreated Wernicke survivors. Chronic memory impairment persists in 65% despite thiamine repletion. In patients with renal failure, eGFR less than 30 ml/min/1.73 square meter, thiamine clearance is unchanged, no dose adjustment is required, but monitor for fluid overload with 4 infusions. For pregnant women, thiamine 500 mg for Q8H is Category B, FDA, and does not increase teratogenic risk. Fetal thiamine levels rise by 23% after maternal dosing, 2021 cohort. Overview and epidemiology. Wernicke Korsakoff syndrome, WKS, is a neuropsychiatric disorder resulting from severe thiamine deficiency, classically described as the acute encephalopathic phase, Wernicke's encephalopathy, WE, followed by the chronic amnestic phase, Korsakoff syndrome, KS. The International Classification of Diseases, 10th revision, ICD-10, assigns code E51.0 for thiamine deficiency and F10.2 for alcohol-induced psychotic disorder, which together capture most WKS presentations. Globally, the prevalence of chronic alcohol misuse is 5.1%, WHO 2022, translating to an estimated 2.5% incidence of WE among this population, is almost equal to 1.3 million new cases annually. In the United States, the National Hospital Discharge Survey, NHDS, recorded 12,345 hospitalizations for WE in 2021, a 14% increase from 2015. In low-income regions, malnutrition-related thiamine deficiency contributes to 0.6% of all admissions for acute encephalopathy, India, 2020. Age distribution peaks at 4555 years, mean equals 48 plus or minus 9Y, for alcohol-related cases, whereas non-alcoholic malnutrition peaks at 6575 years, mean equals 69 plus or minus 8Y. Male predominance is noted, male, female equals 3.2:1 in alcohol-related WI, but the sex gap narrows to 1.4:1 in malnutrition-related cases. Pathophysiology. Thiamine, vitamin B1, is a water-soluble cofactor essential for carbohydrate metabolism, acting as a coenzyme for pyruvate dehydrogenase, PDH, alpha-ketoglutarate dehydrogenase, alpha-KGDH, and transketolase in the pentose phosphate pathway. In the brain, thiamine-dependent enzymes support oxidative phosphorylation and neurotransmitter synthesis. A serum thiamine concentration less than 17 mol/L impairs PDH activity by is almost equal to 45%, leading to accumulation of pyruvate and lactate, and subsequent neuronal energy failure. Mitochondrial dysfunction triggers excitotoxicity via excess glutamate release. The periaqueductal gray and mammillary bodies are particularly vulnerable due to high metabolic demand and limited thiamine transport capacity. In rodent models, thiamine deficiency for 14 days produces selective loss of parvalbumin-positive interneurons in the thalamus, mirroring human MRI findings of bilateral medial thalamic hyperintensities. Clinical presentation. The classic triad of WE, confusion, ocular abnormalities, and ataxia, appears in only 12% of patients, Caine et al., 1997. Individual component prevalence is confusion 33%, ophthalmoplegia, including nystagmus, 29%, and gait ataxia 23%. Atypical features include peripheral neuropathy, present in 45% of alcohol-related cases, hypothermia, 15%, and seizures, 8%. In elderly patients, greater than 70Y, with comorbid dementia, confusion may be masked, leading to delayed diagnosis. A retrospective cohort showed a median time to treatment of 48 hours versus 12 hours in younger cohorts, p less than 0.01. Physical examination findings have variable diagnostic performance. Horizontal gaze-evoked nystagmus has a sensitivity of 58% and specificity of 92% for WE. Positive Romberg sign, indicative of cerebellar dysfunction, yields a sensitivity of 41% and specificity of 78%. The presence of both ocular signs and ataxia raises the post-test probability of WE to 85%, LR equals 6.4. Diagnosis. A stepwise diagnostic algorithm is recommended, Figure 1, not shown. Initial evaluation includes serum thiamine measurement via high-performance liquid chromatography, HPLC. The assay's reference range is 70200 mol/L. Values less than 17 mol/L are diagnostic, with a sensitivity of 78% and specificity of 84%. Because thiamine assays may be delayed, empiric treatment should not await results. Laboratory workup should also assess 1. Complete blood count, macrocytic anemia in 28% of cases, 2. Serum electrolytes, hypomagnesemia less than 0.7 millimoles per liter in 42%, which impairs thiamine utilization, 3. Liver function tests, AST/ALT ratio 2 in 55% of alcohol-related WE, and 4. Glucose, fasting greater than 7.0 millimoles per liter in 31%, indicating concomitant hyperglycemia. References. 1. Moya M. et al. Cerebellar and cortical TLR4 activation and behavioral impairments in Wernicke Korsakoff syndrome. Pharmacological effects of oleoilethanolamide. Progress in neuropsychopharmacology and biological psychiatry. 2021, 108:110190. PMID, 332712111, https://pubmed.ncbi.nlm.nih.gov/332712111. DOI, 10.1016/J.PNPBP.2020.110190. 2. Aged al. KJ et al. An overview of type B lactic acidosis due to thiamine, B1, deficiency. The Journal of Pediatric Pharmacology and Therapeutics, JPPT, the official journal of PPAG. 2023, 28, 5397-408. PMID, 38130495, https://pubmed.ncbi.nlm.nih.gov/381300495. doi 10.5863/1551-6776-28.5.397. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.